Hi, Dr. Haas. Thank you so much for joining us today.
Hi, Diana. Thanks for having me.
You have a very unique angle as a physician that you not only have a great deal of empathy and compassion for your patients, but you also are a patient yourself with endometriosis.
That's right. Yeah, it has been a long journey, not unlike so many of the women that you have on your show and talk to. So yeah. I had my first issue with endometriosis when I was 17. And of course, it wasn't diagnosed until I was 33. So definitely had a long journey as far as getting the right diagnosis and the right treatment. And then, of course, getting the diagnosis was just another beginning of the rest of the journey. It was another 10 years before I had it definitively taken care of.
Wow. See, that's something that I think it's liberating after years of not knowing what's wrong with you, having suspicions, but not knowing. And as we know, the average diagnosis is 10 years, 10 to 12 years. So once you get that validation that something is actually wrong with you, this isn't psychosomatic, this isn't in your head, you do have a disease, the next step is okay, but then what else? What do I do next? What are my treatment options? And as a clinician, for you and also as a patient, how were you able to find what worked for you? What was the process like?
Ooh, yeah, it was it was a long one. And I like to share my story just because I think we've come a long way since I was 17 in the medical world, but we still have some work to do. We still have a ways to go. So when I first went in to the emergency room at 17, I had what's called an ovarian torsion. And so my ovary had twisted because it had endometriosis on it. And I was at that time told that it was just a cyst but it turns out it wasn't just a cyst, it was endometriosis. Well, I was then put on birth control forever. And when I was 33, after years of so much pain, I went into the hospital again, into the emergency room with an appendicitis, or so we all thought. And when the surgeon, opened me up to take out my appendix, he called the OB on call and said, look at this. It's not just an appendicitis. She has endometriosis everywhere. And so they decided then, because so often doctors don't work together in that surgical moment, right? And so I had my appendix removed, and then the OBGYN on call said, well, let's just close her up. We'll start her on Lupron for forever. Well, I was 6 months out from getting married, and that was just like a devastating thing to be told at that time. And even though I knew about treatment for endometriosis and that suppressing estrogen was probably my best route at that moment, that was not an option that I wanted to have 6 months before my wedding. And so I ended up saying, well, I'm going to try everything natural. I'm going to try taking just anti-inflammatories and acupuncture and all the things that we do to try to manage our endometriosis. I did even as a physician. So it wasn't just, pain medicine. It was like, okay, what am I going to do to try to get the inflammation down? And I researched everything I possibly could. And 3 years later, ended up having another big surgery because the endometriosis was all over the bowel. And that's part of the story I like to share because it's not something people understand about endometriosis and how so many women actually have implants, the endometriomas on bowel, and they have IBS-like symptoms and severe pain and a lot of gastrointestinal symptoms during their periods. I think that's something that's super underdiagnosed in the medical world. So
Yeah.
I ended up having lots of surgeries to kind of untangle bowel and things like that. But the challenge was that I needed a general surgeon to do some of that, and I needed an OB/GYN to supervise. And it was extremely difficult to coordinate those two. It took years to find that right team. It actually ended up being Dr. Seshkin and his team that helped me with that multidisciplinary approach.
And I think that's interesting that you said multidisciplinary because that's something I think that more and more we're seeing happen, that there's teams of doctors working because there was, a myth, and obviously I'm not a physician, but there was a myth that endo was only reproductive organs.
Right.
There wasn't a belief that it could be extra pelvic. It could go to your appendix. I also had appendix, and they thought I was having appendicitis, but it really was endo, and they had to remove it. We've also heard the stories about those who have lung collapse because of endo. So now it's having all different kinds of specialists work together who can operate on these organs with a doctor such as a Dr. Sechkin, an endo excision specialist who's overseeing what's going on with all of it. And it really is a full body disease.
Absolutely. Yeah, absolutely. I mean, I could share one of my stories. I've now had multiple surgeries, as I glean you have as well.
Yes.
And so many of us have, but I went into the emergency room probably 3 years after the appendicitis with a bowel obstruction, which is about the most painful and miserable thing a person can go through. And I was so ill and I knew exactly what was going on. So at this point, I had been practicing medicine for, more than 10 years, and I'd been taking care of patients with endometriosis, and I was seeing an endometriosis specialist in Texas, and I knew exactly what was going on. And even with that knowledge and having a CAT scan that showed I was having a full bowel obstruction, the medical team at the hospital said, well, let's just wait until her period's over. Let's just watch her in the hospital. And so I was in the hospital for 36 hours with a full bowel obstruction with a gastroenterologist colleague of mine saying, let's just wait till your period's over because I'll bet the obstruction reverses. Well, that's not even how it works. And it was incredibly frustrating for me. And it's a life-threatening issue. And I just felt like my mission, I just remember being on the floor of this hospital bathroom. I was so ill. And I just remember thinking, okay, my mission, if I survive this, is to educate all of my colleagues on what this is really all about. And from that moment, I literally sent an email and I started getting connected with the Endo Found while I was still in the hospital recovering from what ended up being a full bowel resection surgery. The next day, I had 19 centimeters of bowel removed because it was completely obstructed from endometriosis.
I am so infuriated hearing that story, and it's medical gaslighting in so many ways, and also not just gaslighting because they knew something was wrong, but they thought somehow by getting your period it would resolve the issue, which is just medically. I mean, it's just medically incorrect. So for me, to hear that as a patient, I keep hearing stories from individuals with endometriosis and adenomyosis that are having a lot of similar things where they're like, I know what's wrong with me. Why is no one listening? And here you are, a doctor, and you know your body and you know medicine, and they're still not listening to you. It's incredibly disempowering.
I try not to vilify my fellow physicians, right? They're not the villain here. It's really about how we were all educated.
Mhm.
I got zero endometriosis education in my undergraduate medical school education. It was later, I'm a family physician. So as a family doc, I learned more in my residency about what it was. And what's so interesting to me over these past 10 years of dealing with all that I have going on, the docs were just taught differently about it all. And I think that that's why I feel like my mission, my reason for joining the Endometriosis Foundation was that I wanted to learn how I could better educate my fellow physicians, and which isn't easy to do. I'm not a surgeon. And so for me to go and educate a surgeon just isn't going to happen. But I now am faculty with University of Washington School of Medicine, and I teach first and second year students. And my mission in that is that no student is going to get into their third and fourth year without knowing all about endometriosis and how it can present. I do a lot of case-based learning, and I incorporate endometriosis whenever we're talking about acute abdomen and severe abdominal pain in a female. It's like you've always got to have that on your differential. And if you're not thinking about it in your first year of school, you're going to not think about it in your third, fourth, and then 10 years down the road as well.
In so many ways, you were fortunate that you had the ear of physicians when this was happening with the bowel restriction, or sorry, obstruction. Um, for someone who could be in a similar situation and who knows something is wrong, but they're being told, let's just wait it out, or any of those things, how do they advocate for themselves?
That is such a great question, and one that I get a lot. So I love when people say, how can we advocate for my sister, my mom, my friend, myself, right? And so the major thing that I think I like to teach my students, but I also like to teach my patients, is that when you're talking about something like pain or you're talking about endometriosis, talk to your doctor about the quality of life that has been altered. What are you not doing anymore because of endometriosis? Like, were you a world traveler who doesn't travel anymore because you're worried about an obstruction, for example? I mean, that's my story. I was doing a lot of global health and traveling, and I stopped traveling because I was afraid I would have another bowel obstruction while I was in India. You talk to people about, what are you missing out on? Are you choosing to not show up for events in a 2-week period out of the month, right? That means 50% of your quality of life has been impacted. So pain aside, women tend to not talk about their pain either. It's stigmatized. And then you have a professional woman say, okay, I'm in a world of men, and the last thing I'm going to do is talk about my period, right? So you're not going to talk about period pain or anything related to it. And I think that, you know, I want to destigmatize the talking about periods so that women can know what's normal, what's not normal, but also having their partners know what's normal and not normal. So I guess I would just say that, talking about the whole impact on life and what you're not doing because of the endometriosis, or what you don't know is endometriosis, but as a period that's a bad period. You should never have 50% of your life altered because of something going on. That's not normal.
And with invisible diseases like endo, um, sometimes there's a little bit of disbelief, and doctors can say, well, what's going on in your emotional life? Is there any kind of stress? I've been told by individuals that some people have said, well, maybe you're stressed over boys, for high school students, and it might be, well meaning, but how does a patient, should a patient convince a doctor their pain is real, or should you go to the next doctor who might just believe you while you're saying, these are my symptoms, these are my quality of life issues?
I believe that, a physician should be listening to anybody's pain and talk to a patient, no matter how old, about taking a stepwise approach to dealing with their pain. And so obviously all period pain isn't going to end up in a surgery, but you can walk someone through about what's expected and what's not expected, right? And so you've got a young girl in school, who's maybe missing school. I think that, to me, is always, should raise a lot of red flags if a girl is missing school. We all need to be rallying around her and make sure she can have the same opportunities that everyone else has, and it shouldn't be limited by pain. So I always like to treat pain aggressively, or find out why they're missing school so that we can get in and help get them taken care of. If they're in a situation where their physician isn't listening to them, or there's a perception of that, I think there's a lot said to having an advocate, whether it was a parent or an aunt or whomever, who can advocate for that person to say, listen, if you're not going to be able to address this pain, do you have someone else who could? And really being direct, because I think that physicians, again, I'm always trying to not vilify us, because I think we're all going to medicine to help people's suffering. And
Mhm.
sometimes they don't hear, or we as a profession don't hear the suffering in the story. And so having someone relate that, like, okay, I know she's saying she had a bad period, but what she's really trying to tell you is that she's curled up in a ball and vomiting and not able to go to school. There's so much around the suffering of this that I think that's um, really the gist of kind of how to approach it. So I don't I like people to try to work with their current physician or their current practitioner in dealing with what's going on. And if they can't, quickly get a second opinion, third opinion, listen to friends, talk to people about who is listening.
No, that's some great advice. In terms of options for endo, it seems like there's just a few. Can you discuss some of those current options that we have, and maybe something that could be a possibility in the future from what you might be hearing about in the research community? Is there anything?
Well, yeah. And so, I, through Endo Found, listening to what's happening in the research community, and I'm very excited about a lot of the research, particularly the idea of diagnosing without a surgery. Those are the kinds of things that I think are most exciting. Yes, there's different treatments. Most of the treatments hinge on either strong anti-inflammatory medication or estrogen blocking type medications. And so, we've had medicines like Lupron around for many years, and now there's some pill forms of similar types of medicine that kind of block the estrogen production in the body. And so I think that those are showing to be really, really helpful for a lot of people once they get the diagnosis, but we still are tied to laparoscopic surgery to diagnose it well. And I think that if we are able to identify some biomarkers, if we're able to get some better imaging, I mean, as you know, imaging just doesn't show endometriosis. Very well until you've got secondary scarring or secondary, tethering of, your visceral organs essentially to a muscle. So it's got to be quite advanced to show. And so I think that those are the two areas of research that I'm the most optimistic and excited about.
Thank you. No, that's interesting too, to know that it has to be more advanced in order to be picked up on scans. So you still could have endo, it just might not be showing up. And the other thing too is, right, the pain doesn't necessarily correlate with the stage.
Absolutely. That's right. And, Dr. Sushkin will tell you, and if you look at his website about, so often people will go in and have that laparoscopic surgery, and maybe there's just a tiny bit of endometriosis visible. His technique, he can actually identify the stuff that's not visible to the naked eye. He can dye it and see what else is there. And I think that that's so interesting in, the diagnosis of endometriosis, because we didn't understand for so long why you could look and see one tiny piece and a woman's in excruciating pain, or you could open up an abdomen and see a lot of endometriosis and they just had bad periods, and so it just seems to be very much all over the place. But I think it comes down to that microscopic part of endo, and of course the secondary scarring that happens as well.
Mhm. No, thank you. I mean, I always appreciate your time and your insight as someone who, I said earlier, has firsthand experience, but also just a tremendous amount of compassion and knowledge that you're passing forward on a daily basis.
It's a fun job. I like it.
Well, you do it well.
You're very kind. And thank you for all you're doing and just bringing out awareness. This is a huge part of tackling this big disease is awareness, education, advocacy. So I just really appreciate what you're doing.
Thank you. Thank you very much. We'll talk to you soon.
Okay, sounds good. Thanks so much. Have a great day.